Bismillahirrahmanirrahim. Good afternoon. Welcome you all to our regular weekly session. How should I treat my patient following evidence-based medicine? And as you know, we have been running our GI session, and the GI we have been discussing the hepatobiliary cancer. Last week we discussed of the pancreatic. Today we will be talking about the management of biliary tract cancer, non-surgical portion. So our local faculty is Dr. Sharif Ahmed, who is Associate Consultant of Cancer Care Center United Hospital. Sharif is a very brilliant oncologist. We are always amazed with his performance, and hopefully today he will be enlightening us with all the recent development in the management of non-surgical management of biliary tract cancer. Our overseas guest faculty is Dr. Vineet Talwar, who is a director of the Department of Medical Oncology, Rajiv Gandhi Cancer Institute, Delhi, a good friend of us, always supporting us by his own presence or also providing support from his department. Welcome, Dr. Vineet. Our patron and our president, Professor Ahmed, who is the inspiration, and he is always inspiring us with his virtual presence and always supporting us, encouraging us to go forward. So as per our culture, I would like to request our president, Professor Ahmed, to formally start the session. Then we will go to the presentation. Professor Haisar.
Thank you, Dr. Kamal. Assalamu alaikum, everybody. Heartfelt thanks to Dr. Vineet. Taking lots of pains to enlighten us. The boys are here. They're learning from you. This faculty, local faculty, Dr. Sharif, very bright boy. Without any delay, we shall start. Therefore, subject is very difficult.
So thank you, sir. Now I would like to request our today's presenter, Dr. Sharif, to give his presentation. Dr. Sharif Ahmed.
Hello, assalamu alaikum. Am I audible to everyone?
Yes, and the slides are fine. Please proceed.
With the due respect to Haisar and Vineet Talwar sir and the senior colleagues, I am Dr. Sharif Ahmed, going to present a brief discussion about the biliary tract cancer. Biliary tract cancer comprises the 3% of all GI malignancies. This is a hetero group of malignancies arising from the biliary epithelial cell, and with the diagnosis of late diagnosis with a poor outcome usually. Before going to the main management and other topics, biliary cancer can be subdivided in 3 big groups. First one is intrahepatic cholangiocarcinoma. Second is the extrahepatic cholangiocarcinoma, which can be subdivided into perihilar cholangiocarcinoma and distal cholangiocarcinoma. And the third one is gallbladder carcinoma. There is another subsite, that is ampulla beta carcinoma, which is also classified as a biliary tract cancer. So first of all, we started with the diagnosis. Biliary tract cancer is really challenging, and most of the cases are diagnosed very late. Why with the late diagnosis? Because the non-specific GI symptom, and most of the patient, while they symptomatic become symptomatic, they are usually present in the advanced stages, such as jaundice or biliary with the biliary obstruction. There is another challenges, that is the differential diagnosis of the biliary tract cancer, such as extrahepatic cholangiocarcinoma, which sometimes misdiagnosed with the head of the pancreas cancer, or intrahepatic cholangiocarcinoma sometimes is coincide with the both hepatocellular carcinoma and intrahepatic cholangiocarcinoma. Or there is sometimes it is tough to distinguish between the two subsided, and there is no statistically defined risk group. That patient can be in a risk group, and we can make some screening to diagnose earlier. So as per ESMO clinical practice guideline, what should be the diagnosis guideline if we suspect a patient as a biliary tract cancer? First of all, abdominal ultrasonography is the most useful and available examination for identification of the biliary obstruction, and proceeding the MRI or MRCP should be carried out. And before any biliary intervention, it should be carried out. Why before any biliary intervention? If we do before any MRI or MRCP, we should done before any biliary intervention, because If you do the intervention, it will give me the false imaging regarding the extent of the disease. And ERCP relief of the bile duct obstruction and should be done plus cytology or biopsy if possible. And patient which seems to be undergone surgery with the radical intent, biopsy is not obligatory. Biopsy can be done on the resected cases. And for the patient with advanced or inoperable disease, histological or cytological confirmation is essential. And it can be obtained by ultrasound guided EVAS or metastatic lesion, which can be biopsied percutaneously. FDG PET imaging is not established in diagnosis of the biliary tract cancer. And baseline CA 19.9, it is most important for the follow-up of the patient. And it gives us the guideline in the treatment outcome and follow-up and as a prognostic value. So come to the main point, the management of biliary tract cancer. It can be divided in the local disease, locally advanced, and metastatic. First of all, I like to share this diagram. This is a ECME guideline for treating the biliary tract cancer. Now, it can be divided in the 3 groups. As I said earlier, is the early stage, locally advanced, and metastatic. In early stage, the curative treatment option is surgery, and followed by the adjuvant treatment. Whether adjuvant treatment is beneficial or not, that we can be discussed later on. And locally advanced and metastatic biliary tract cancer can be treated as the same line of treatment with the systemic therapy. There is some role of locoregional therapy. So what is the management of locoregional or early stage biliary tract cancer? If we go through the subdivision, the first one is the intrahepatic cholangiocarcinoma. And radical surgical removal of the clear margin is the only potential curative treatment. Remain in mind too as a prognostic factor. This is the lymph node involvement, size and number of the tumor and grading of the tumor, presence of other satellite nodule, LBSI, PNI involvement. And whether we go for the perihilar cholangiocarcinoma, there is another name is Klatskin tumor. Assessment of the resectability should be correlated or done by according to the Bismuth correlative classification, which has been seen by the right side of the slide. It can be started with the type 1 to type 4, and depending upon the tumor location in the common bile duct, hepatic bile duct, it will be classified, and it guides us how can we go for a curative resection or not. And patient presenting with jaundice, initial radiology should be carried out, that I have said earlier. And another 2 trial is going on. No data is even come out. There is the liver transplantation in the perihilar cholangiocarcinoma in the early stages. And what about the distal cholangiocarcinoma? It is also the curative treatment is the surgical removal, and it should include the removal of the pancreatic head. But in few studies such as Dixon, PV et al., which was published in the 2014, that shows that the prognosis of distal cholangiocarcinoma is better than the adenocarcinoma of the head of the pancreas. And the gallbladder. Gallbladder cancer can be presented in the 2 types, as incidental diagnosis during the operation or surgery or cholecystectomies, or other are the symptomatic patient when we know that this is a suspected case of gallbladder carcinoma. If we incidentally diagnose the gallbladder carcinoma, the first thing it should be done, if during the operation or operative we think that this can be a carcinoma, then we should go for an extended cholecystectomy. And after the histopathology, if we find out this is a gallbladder carcinoma while we receive the histopathological report, and following should be done: the appropriate imaging such as MRI or CT scan, detailed histopathological analysis, and because every test is above T1 and possibility of any mentioned parameters such as T size, cystic duct cut margin, involvement of resected lymph node, grading of the tumor, PSI and LBI investigation requires a resurgery or reoperation. And if the GBC is diagnosed during the imaging in a suspected case, there should be go for a extended cholecystectomy. If evaluation of potential resectability is the key factor, and advanced cases, even 84 is not a contraindicator for resection. providing the location of the tumor. If the tumor is located in the fundus of the tumor gallbladder, it can be easily resected. The prognosis of the gallbladder cancer, if not diagnosed at very early stages, is somewhat inferior to all type of cholangiocarcinoma. So the main topic of discussion in the early stages, whether we should go for the adjuvant treatment and what is the best adjuvant treatment option for the after the surgery or definitive or curative treatment. The high rate of local and distant recurrence following surgery justifies the consideration of an adjuvant treatment. It can be chemotherapy, it can be chemoradiotherapy, it can be radiotherapy. Let's see what will be the best option for the patient. In a recent meta-analysis and published data showed that this meta-analysis was done over the 20 studies involving more than 6,000 patients, where a non-significant improvement of overall survival with any adjuvant therapy compared with surgery alone. That's why any short of adjuvant treatment is significant and gives some beneficial to the patient. And there is no difference between the gallbladder or bile duct tumor regarding the overall survival or treatment outcome when we added adjuvant treatment. The patient who is receiving chemotherapy, chemoradiotherapy did have statistically greater benefit than RT alone. And the greater benefit for the adjuvant treatment was those who were lymph node positive or R1 disease. So, if we discuss about the meta-analysis regarding the adjuvant treatment, the gallbladder subgroup, which is the overall population, gallbladder subgroup says that if you use the forest chart, it favors the experimental arm, it means the adjuvant treatment, though it is not statistically significant. If we also consider the cholangiocarcinoma group, it is also beneficial, though it is not that much statistically significant. But when we go for the node positive disease, in both gallbladder and cholangiocarcinoma, it is statistically significant. We show that the p-value is 0.004. And when efficacy come out for the positive margin, it is also statistically significant, give a greater benefit while we add the adjuvant treatment. And this is another study, what is the comparing of the radiotherapy and as an adjuvant treatment. This is the SWOG S0809 is a phase 2 intergroup trial of adjuvant capecitabine and gemcitabine followed by radiotherapy with concurrent capecitabine in extrahepatic cholangiocarcinoma and gallbladder cancer. What is the eligibility criteria? Is the extrahepatic cholangiocarcinoma along with the gallbladder cancer after resection, where stage 2 to 4 with N0 or N positive, or where positive resection margin where there is no metastasis and performance status is 0 to 1. All the patients receive 4 cycles of gemcitabine along with the capecitabine is a 21-day cycle followed by concurrent chemoradiotherapy with capecitabine. And the radiotherapy dose was 45 to the regional lymph node and 54 to 59.4 to the tumor. And result is promising in the 2 year. As a R0 section shows the survival estimate was 65%, and the in R1 section is the survival estimate was 45%. So this combination was well tolerated, has a promising efficacy, and provided clinician with a well-supported regimen. This trial establishes the feasibility of conducting a nationwide adjuvant trial in extrahepatic and gallbladder carcinoma and provide a baseline data for future planning of the phase 3 trial. It's a phase 2 trial, as the N number is very small, but it can give us an idea that if we add the chemotherapy followed by the concurrent chemoradiation, it can be beneficial and estimated a survival benefit, especially in the R1 section. And there is another meta-analysis which is called as a Prodigy 12 Accord. It is a multi-centric open-label randomized phase 3 trial in 33 centers done between the July 2009 to February 2014. And 196 patients was randomized is 1:1 ratio for within the 3 months of the surgery, whether it can be R0 or R1 section. To receive either gemcitabine in 1 month and for the 12 weeks, and another one was as an observational arm. And the primary endpoint is relapse survival and the quality of life. The median follow-up was 46.5 months. And if you compare the relapse survival and the overall survival, there is no statistically significant difference in the relapse survival between two arms. Whether it is that there is a survival, relapse benefit in the treated arm, that is 30.4 months compared to observation which was 18.5 months. But overall survival was also not statistically significant, but there is a clear-cut benefit of the median survival rate, which is 75.8 months compared to 50 months in the observation group. So now come to the locally advanced biliary cancer. The limited evidence was the best approach for the last trial of chemotherapy similar to the metastatic treatment. So the locally advanced and metastatic biliary tract cancer can be treated as the same treatment mode guideline. But there is something new that we can offer the patient as a localized treatment such as RFA, microwave ablation, and other sorts of local treatments such as TACE or drug-eluting beads concurrently with the systemic therapy. And recently, the river radioembolization with yttrium-90 particle shows a promising result, and patient become more resectability after treating with the Y90 radioembolization. There is a two recent trial is going on. One is the SARCA study. Especially this is helpful for the intrahepatic cholangiocarcinoma. The eligibility criteria is unresectable intrahepatic cholangiocarcinoma with no prior chemotherapy with a good performance status. The patient was 1:1 was randomized, and one group firstly treated with the SR spear with radioactive yttrium-99 regimen with microsphere followed by systemic chemotherapy, and another one was treated with the systemic chemotherapy. Still no data is not published and it is going on trial. There is a study follow-up for the 18 months. But interim, another study was the STOCS study. This also treated, the patient was treated with the yttrium-90 spheres and followed by the systemic therapy. So experience in growing with the use of radioembolization using yttrium-90 microsphere for patients with intrahepatic cholangiocarcinoma. Prospective randomized data are lacking till now, but a pooled analysis on the ongoing study and other several small data sets showed that there can be an improvement of the median survival up to 15 months and response also 28%. And importantly, the patients who study converted the patient with the unresectable cancer with the internal hepatic cholangiocarcinoma can be resectable and can turn to be resectable with the treatment of yttrium-90. And what about the metastatic cancer? It can be treated, I mentioned earlier, that it can be treated with the locally advanced and as the same pattern. Surgery has a very limited role, mainly with the chemotherapy-based management, and with a limited benefit up to 20% response rate. And what about the median overall survival rate? In best supportive care, it is 2.5 to 4.5 months, and in the chemotherapy arm, it can be 12 months. And most of the thing is that 15% patient is really unfit for the second-line therapy about the disease progression. And where the treatment with the advanced cancer, biliary obstruction can be recurrent, and biliary obstruction or biliary management should be done, such as with the stenting or biliary bypass. And what is the role of the radiotherapy in the advanced biliary cancer? The role of radiation therapy remains unclear in the treatment of locally advanced but non-metastatic biliary cancer. Chemoradiotherapy has been considered as a possible option according to the non-randomized studies with median survival rate between 9 to 14 months. The French FFCD 9902 phase 3 trial compared the chemoradiotherapy with the chemotherapy alone in this setting. Patients were randomized in two arms. One arm is getting the chemoradiotherapy with 50 gray with concurrent 5 and cisplatin, and another arm is getting combination of chemotherapy with gemcitabine and oxaliplatin. The trial was closed before the completion of planned inclusion after the enrollment of 34 patients, as there is a clear-cut advantage of systemic chemotherapy arm, with the overall survival was 20 months versus 13.5 months in the concurrent chemoradiotherapy arm. And recently, data shows that the IMRT has shown to allow safe dose estimation, and we can give a more dose to the or make a more treatment outcome and response rate. And this study was published in the Green Journal in 2019, and with a small case series which has the published data from the 2000 retrospectively and prospectively combined, that was compared between the conventional radiotherapy and image guided IMRT. And this series represents the first clinical outcome of biliary tract cancer treated with the IGRT IMRT in comparison to a cohort of patients treated with conventional technique. IGRT IMRT has feasible for biliary tract tumor wanting a further investigation in a prospective clinical trial. So, what about the systemic chemotherapy for the advanced and adjuvant settings? The first line of treatment is always the gemcitabine based treatment. When you combine the gemcitabine based treatment with the cisplatin, when the combination chemotherapy shows a median survival rate is 4.5 months. If it shows that there is a two big study was done, one is the ABC02 study, one is the biliary tract 22 study, and the PFS progression-free survival was, and both OS is much more greater in the combination arm. And this is the subgroup analysis, and all the subgroup analysis shows that the gemcitabine and cisplatin is the standard of care for the first-line treatment of good performance status patient with advanced biliary tract cancer, regardless of age, gender, primary tumor site, locally advanced or worsening metastatic stage of the disease, and prior any other therapy. But there is a outcome score in the poor performance status patient. So what are the other options for the first line treatment? There is the ongoing data comparison was going on, the combination of S1 along with the gemcitabine and cisplatin, and it shows that not significantly improved in the triple combination. The overall survival is 13.5 months, whereas in the gemcitabine and cisplatin it is 12.6 months, and even there is a not significant improvement of the progression-free survival. So another option going trial was recurring right now. There is the SWOG 1815, which the randomized patient was treated with the two arm. The inclusion criteria is the untreated locally advanced metastatic biliary tract cancer with a good performance status. In the randomized 2:1, the one arm is getting gemcitabine cisplatin along with nab-paclitaxel, and there was going on the conventional gemcitabine and cisplatin. And what is the primary endpoint? It is the overall survival, and secondary endpoint was progression-free survival and safety. The clinical trial was going on, and the estimated primary completion date is the January 2024. Still now there is a disease progression after the first line treatment. What is the standard line of second line treatment? The second line chemotherapy has historically based on the retrospective and small phase 2 evidence. Due to the aggressive behavior of the cholangiocarcinoma, actually few patients are considered to be the fit for the second line treatment. And again, along with the second line treatment, active symptom control such as early detection management of the biliary tract obstruction or cancerous symptom is the most important part of the treatment as when we go for the second line treatment. And there is a meta-analysis which showed the 25 studies of phase 2 and more than 700 patients. Is a not significant improvement. There is no as much weighted mean difference between the PFS, OS, and regression rate. Then come to the ABC06 study. Is there any standard second line treatment? This was the randomized phase 3 trial, open label done. Advanced BTC along with the good performance status patient, and patient was 1:1 randomized in two arms. One arm getting the best supportive treatment or active symptomatic control treatment, and the other one was getting the modified FOLFOS along with active symptom control. And the primary endpoint was to find out the overall survival. And the patient was randomized. What about the initially recruitment of the 290 patient, and randomized the randomized was done on the up to 162 patients, and it shows that the FOLFOS improved the overall survival after the progression of the disease treating with the gemcitabine and cisplatin with a clinical meaningful reduction of the risk of death. If we find out that the overall survival was in the Observation arm is 5.3 months, whereas the treatment arm is the 6.2 months. If you go for the 6 month survival rate, it is 35% compared to 50.6%, and 12 month survival rate is 11 months versus 25 months. It's almost double. So Fallpox was active symptomatic management is a new standard of care as a second line treatment. What about the other combination with the biological agent? And there is a several combination. A small trial was going on or done. Gemcitabine with cetuximab, allutinib, panitumumab, sorafenib, cediranib. None of them showed a comparable or effective, statistically effective overall survival benefit. If chemo arm, it was the overall, it was 11.7 months, whereas the with biological, it is near about 11, 10, 9, and 8 or 8 months. So in the era of immunotherapy, is there any role of immunotherapy in the management of advanced biliary tract cancer? Yes. This is a multicentric single-arm phase 2 trial going on with the pembrolizumab. Inclusion criteria is cholangiocarcinoma with progressive disease after at least one line of treatment with a good performance status, and patient sample with the PD-L1 evaluation. And what is the main objective response rate? And secondary one is overall survival, progression-free survival, and the safety or tolerance. This study is also an ongoing study, and the objective response was in the population of 5.8%. In the PD-L1 positive one, it was more. This is 6.6%, while the PD-L1 negative is the less, is 2.9%. And there is a partial response of 6% in the overall population in respect to the PD-L1 status, and the PD-L1 positive patient has a 4%. And the overall survival data or median duration of response is not reached yet. And the combination of durvalumab with the temozolomab, they also show, it is the ongoing trial, which is presented at the ESCO 2019. They also show some objective response of the disease as a partial or static disease. With nivolumab along with gemcitabine, 30% metastatic cholangiocarcinoma was recruited in the study with a chemo patient, no prior treatment, and it was found that the objective response was only 37%, and the median overall survival was 15.4% per month. It is a small group of cohort study which should be encouraged out to evaluate the immunotherapy in the advanced biliary tract cancer. And what are the future development? The future development, there is a development trial of multiple trials going on. Is there any role of biological driven or mutation driven treatment? But it was found that along with the subdivision of the biliary tract cancer, it is a biologically heterogeneous disease, especially in the intrahepatic cholangiocarcinoma. It shows the KRAS, BRAF, and PIK3CA and FGFR2 mutation more along with the IDH1, whereas the extrahepatic and biliary tract cancer shows more mutation in the HER2 and KRAS. So this is a biologically heterogeneous disease. Intrahepatic cholangiocarcinoma mostly shows the KRAS, FGFR2 fusion, and IDH1 or 2 mutation, where the gallbladder shows the EGFR, HER2, and PIK3CA, and the extrahepatic shows the HER2 and KRAS mutation. So with this mutation, there is a ongoing trial is going on, starting with the 2019. There is a proof trial targeting the FGFR2 gene. The patient with unresectable or metastatic cholangiocarcinoma with FGFR2 gene fusion. Infigratinib in the one arm along with the gemcitabine cisplatin. And the primary endpoint was the progression-free survival, and the secondary endpoint was the overall survival. And this is the ongoing study. We cannot know the internal pull data also right now. There is another trial is going on. There is the flight 302, also targeting the FGFR2 rearrangement, and patient was randomized in the 1:1 arm, along with the one arm is getting the pemigatinib with as a continuous dose, another arm is getting the gemcitabine and cisplatin. And in case of intrahepatic cholangiocarcinoma, there is a high number of IDH1 mutation. It was found that the IDH1 mutation is seen with the 13.1% patient in the intrahepatic carcinoma, whereas it is 0.8% in the extrahepatic cholangiocarcinoma. And So there is a study was designed, name as Carl study. Study, and it the eligibility criteria has more than histologically confirmed diagnosis of cholangiocarcinoma with centrally confirmed mutation of IDH1. It is by NGS with a good performance status, and at least one prior primary treatment with a gemcitabine-based chemotherapy. And pre-screening mutation was done. All the patient was 2:1. Renovation was done. One patient is getting the placebo treatment, and the two patients is getting as a ivosidenib as a IDH1 targeted therapy. It is also an ongoing study, and the interim data shows that there is a medium overall benefit in the treatment group, which is 2.7 months, and the 12-month follow-up shows that there is a response rate of 22%. And there is another study going on, the MyPath study, and this study was going on to evaluate the role of malagent in the advanced treatment of the biliary tract cancer. HER2 as the target therapy in the MyPath. There is a HER2 is amplified in few cases of the patient in the extrahepatic biliary cancer and the gallbladder, not in the intrahepatic cholangiocarcinoma. An estimated study completion date is 2020 and December. So also another target thing is the BRAF B600E. There is the ongoing phase 2 trial is going on, where the B600E mutation was positive. Metastatic cancer had been treated with one prior systemic therapy. And there is a study is going on the ROAR basket trial. We showed the efficacy and safety of darbepoetin along with the tremetinib in patients with the BRAF 600E mutation, where it shows the treatment guideline along with according to the eCME guideline. The early treatment, there is a surgery plus minus adjuvant chemotherapy or chemoradiotherapy. So after that, there is a change. There is a recommendation of level 1A that adjuvant treatment always help to improve the overall survival and progression-free survival. And as we treated with the locally advanced or metastatic disease, till now there is no standard. Now, as the ABC06 trial, FOLFOX is the new standard of second-line treatment along with the active symptom control. And the depending on the target therapy, molecular testing is mandatory, especially in the intrahepatic cholangiocarcinoma. There, because of there is a high number of possibility of IDH1 mutation, and the role of local treatment is evolving day by day, such as radiotherapy, especially in the intrahepatic cholangiocarcinoma, to improve the resectability, ETM, and the radioembolization. So, what are the take-home messages? Diagnosis of biliary tract cancer can be challenging because of sometimes there is a diagnostic dilemma whether it is the primary origin or not. Radical surgery is the only curative treatment for patient with identically diagnosed post-colectomy reoperation with the radical should be considered in patient with above the stage 1B. Well-established first-line chemotherapy with minimal improvement over the last decade. But right now there is a development of second-line chemotherapy with FOLFOX is conveyed overall survival benefit in second-line setting. Patient with initially inoperable non-metastatic disease should be rediscussed at MDT with a view to salvage surgery in event of good response to systemic or local regional treatment, including participation in the clinical trial. Radiotherapy may be considered in patient with localized disease after the first-line chemotherapy. Patient should be encouraged to participate in the clinical test because we need more data regarding the good outcome of adding the chemoradiotherapy after the first line of treatment. And radioembolization may consider in patient with inoperable intrahepatic cholangiocarcinoma, usually after the first line of chemotherapy, and patient should be also encouraged to participate in the trials. Targeted treatment seems to be promising. Trial on first line setting are still awaited, and the pool data from the ongoing trial is still awaited to show the beneficial effect. Role of immunotherapy may be beneficial, but result yet not to be published as a big data. No, a big data or no, the phase 3 randomized trial is available. So thank you everyone for the patience sharing.
Thank you, Sharif. It was a quite elaborate presentation, I will rather say. So quick comment from Dr. Vineet, then we will go to the question and discussion.
No, it was a good data which we have gone through, and he is in such a short span, he has tried to encompass the most of the factors. When we talk of biliary tract cancers, we talk of the whole gamut of the gallbladder cancers, the cholangiocarcinomas, the periampullary carcinomas. But generally, we as South Asians in India and Bangladesh, we focus more on the gallbladder cancer, as the cholangiocarcinomas are still rarer. So when you come to the West, gallbladder or the biliary tract cancers are almost unknown. And that is why you'll see that the data for biliary tract cancers are either taken from South America, from Chile, whenever they do studies, or they take our help in the South Asian countries. In India and Bangladesh, the Indo-Gangetic belt, wherever the river Ganges flows, it is having a very, very high concentration of the bile duct cancers. Probably either it is because of the diet factors or some other heredity or some other factors which are yet to be found out. But there is a very, very high concentration of gallbladder cancer in our parts of this world. So having said that, I think it was a good presentation. We can go ahead. Dr. Kamal, please.
Thank you. So I have collected gathered some questions that wanted to discuss. Then we have some few in the chat box. So first question is that sometimes, we see radiologically there is a suspected mass in the gallbladder. We are trying to give some chemo, but ethically we need to have some proof. But again, we are scared to put a needle, because putting a needle may cause some biliary surge in the abdomen. So in this type of situation, shall we go for FNSC from suspected gallbladder cancer?
No, if it is a metastatic situation or loco-regionally advanced, which is inoperable, definitely you have to, if you have to create a morbidity in any person, you have to justify it at the beginning. So you cannot go on hunches or oversized perhaps. It has to be a definitive diagnosis, and then only we should proceed.
So when we are not planning for any surgery, if we are starting upfront chemotherapy, we must have a tissue, because so the message is, under no excuse, we cannot use a chemotherapy. What he was telling, that you are going to do some damage. So unless we have adequate proof, we cannot put in chemo to somebody's body. So that is the message. So what about re-resection, incidental finding, re-resection? What I was picking up, that there are some quite good data that re-resection is beneficial, and it is significant survival benefit. It is showing, and there was a consensus statement of T1B, T2, and T3 disease. If this incidental diagnosis is done, they have recommended that the re-resection should be done, and 40% 1 year recurrence is there. So if the re-resection is done, we can bring it down. So any comment on that, Dr. Vineet, the re-resection?
No, definitely. If you are able to get negative margins, and if you are able to do the proper dissection, then definitely you get the benefit, as you have rightly shown. And very many times we come across patients in our OPD also who have just got a cholecystectomy done, and during the cholecystectomy they found the disease. So these are the patients who merit re-resection. And per chance, during say cholecystectomy, if they found that there is peritoneal disease, then probably you can leave them and you continue with the further treatment.
So very tricky thing, say somebody has done a resection, they have taken the part of the liver, which is negative, but somehow they have not done the nodes, taken out the nodes. So will you consider it as an adequate re-resection, or you will say, no, we need to know the node status? The surgeon is telling it is normal size node, and as you are going to give some adjuvant chemotherapy, So I don't chase the nodes.
No, as you and I know, when we do a radical cholecystectomy, we have to address all these things. Plus, along with lymph nodes, you have to take a shave of the liver also, the area which is physically in touch with the gallbladder. So all these things have to be taken into account. And prior to going for a radical cholecystectomy, if you can do a laparoscopy and see that there is no peritoneal disease, you'll avoid unnecessary big scars and big resections, which could have been avoided prior. So definitely, you are very right. We should assess the lymph nodes, assess the undersurface of the diaphragm, assess the part of the liver which has to be taken off. All these things have to be done in a radical cholecystectomy.
Any comment
And of
about port
course,
resection?
pardon?
Port resection, say laparoscopic
So
cholecystectomy.
port resection,
Are you practicing it?
port resection seems very, very, what should I say? The surgeon becomes greedy that yes, if I take out the port, I'll be able to take out the disease also. But if you've done a good resection and you feel that the port area is not involved physically, then probably you do a port resection. But trials have shown doing the port resection and everything, the overall survival does not change much.
Right. So that was the point I was coming, that even we find some port metastasis, but till now no trial has proved the benefit of port resection during the extended cholecystectomy. So
But then if you tell the surgeon, no surgeon will always say, yes, I should take out the port and we'll get the benefit of the doubt. But till now, the studies don't.
Yeah, so this is actually real life. Every day we are facing this type of challenges. So we know that whenever we are diagnosing a biliary tract cancer, hardly it is the early stage. It is always a advanced cancer. So whom to offer adjuvant and what about second line? So ABC02 is still the gold standard, 11.6 months, because Sharif has shown so many data, but unfortunately hardly had shown anything. But if you take a look at the adjuvant data, say all this trial, I mean, no great story. Even in this German study, they have changed the design to compare capecitabine with Gemcis. So that is also really interesting, that what we are waiting for. So with this type of situation, I mean, what is your comment? I mean, I see Sharif told many things, but for us to take home, I have a patient T2 or T1B or T2, okay. I want to give adjuvant. Will you recommend still Gemcis, or you want to recommend something else? And if Gemcis, for how many months or how many cycles?
That's a very good question. There is no well-defined study to say that, yes, this drug is the drug which will give the benefit. So when, at the outset, you have to be sure that whatever you have taken out, all the margins are negative. That is the most important thing. And the second is you have to do adequate surgery, like what we had discussed in the last question. So when you are sure that you've done an adequate surgery and you're sure you got a negative margin, then only you embark on adjuvant treatment. And when you embark on the adjuvant treatment, you have to do some risk stratification also. The size of the tumor, the lymph nodal mets, the positive margins or negative margins, the LVI, and also, the patient-related characteristics, what is the performance status and general condition of patient. And another important thing which we most of the time overlook is the post-op complications, if they are there, because if they prolong over a long period of time, then of course the benefit of adjuvant treatment is blunted. So all these things have to be taken in mind. If you have taken all these into context, then probably I feel we can give 5-FU congener like capecitabine as an adjuvant in these patients, or as you have shown all these trials, gemcitabine alone can be given in these patients, although it has not made much of a dent in the overall survival. So I feel oral capecitabine, or you can give gemcitabine. The treatment would be about 4 to 6 months. That should be adequate.
So the So the treatment should be 4 to 6 months. And what Dr. Vineet Talawar was telling, that we are always looking at the node and the margin, we forget about the performance status. And we don't look at that. And sometimes it takes so many months. After 3 months, they come and we happily give them adjuvant. Not
Exactly.
considering maybe there is no value of giving some adjuvant after such a long period. And this adjuvant is not adding so much thing. So maybe in that case, keeping an observation could be a good choice, rather putting some chemo and putting some toxicity. So whenever we are thinking of any adjuvant, I think that we should be very cautious to calculate that how much benefit we are expecting and how much chemotherapy in course of financial and physical toxicity we are offering. If it is not rational, I think we should not chase it. So regarding the adjuvant, then whenever we are talking about adjuvant, the question of neoadjuvant comes. So who will be the neoadjuvant candidate and any scope? So this is then a question comes to my mind. If I plan for neoadjuvant, what type of protocol and for how many cycles? So I have picked up one study. They have said year 2197. There are a few more studies, but not a great data. Every I saw 30, 40 patients, not so-called 100, because even it is a multi-group, multi-centers study they have done. They have taken 4 cycle 3-weekly GMCs, and then they have restaged and then gone for surgery and then again given adjuvant. And they have shown that there is some benefit, but still not a very well-established protocol. So I want to hear from Dr. Vineet that what is your practice? Are you practicing neoadjuvant in biliary tract?
See, again, this question is a very contentious question. Good you got this in the discussion. Here is what, the actual multidisciplinary committee which comes into vogue. You have the surgeon, you have the radiotherapist, and you have the medical oncologist. So if the surgeon says that, yes, this is borderline resectable, or this patient may come under the ambit of surgery post neoadjuvant treatment, then these are the patients who should be taken up for neoadjuvant treatment. But in gallbladder, as you know and as I know, there are not very many people who come under the neoadjuvant ambit, because most of the times, unfortunately, they come with very, very advanced disease, owing to the fact that the location of gallbladder is such that patients become symptomatic only after they have the metastasis.
I totally agree with you. That's why I said whenever we diagnose it's already advanced stage patient. But these are, some academic exercise that we feel like, maybe this could be that locally advanced, give some chemo. If we are really finding that the patient is doing great, maybe at the middle of the way, we can do a restaging by imaging and we can discuss. But I think the very important point that you raised at the very beginning, that laparoscopic evaluation is becoming a mandatory portion for almost all GI surgeries, because before going for putting a scar, to do a laparoscopy and because we know peritoneal metastasis is not always possible to pick up by imaging, not even by PET CT. So laparoscopy is a very rational approach, as you say. So now, almost at the end, we know that when there is a high bilirubin, there is a recommendation we can try with gemcitabine. If there may be a response, it may bring down. But what is the level cutoff that you practice, that highest this you can give, and beyond how much you will not give chemotherapy? Is there any such cutoff? Because people said rule of 5, 6, 3 times. What is your practice?
Well, that's again a very good question. But prior to that, we have to see why the bilirubin is rising. There are 2 major, groups which lead to hyperbilirubinemia. One is the surgical obstructive jaundice, where you can have a blockage of the biliary tract, the common bile duct, wherever it might be. These are the patients who can be subjected to stenting. You get the bilirubin down, and then you can proceed. The second one, which probably you are referring to, is the parenchymal jaundice, in which you find that you've done an ultrasound or a MRCP. You find that the bile duct is patent, and you have multiple hepatic mets. So there you have to use your clinical discretion. We don't go beyond 5. So beyond 5, you are more or less trying to create a big problem for the patient, because these patients don't rally around. And as such, if a patient comes with the parenchymal disease with a bilirubin of say 3 or 4, the patient at that point of time also is in a very poor condition, poor performance status, general condition, malnutrition, and they have host of other things associated with that. So arbitrary cutoff is 5. We start with the single agents, and that too, after carefully discussing with the attendants and using our clinical discretion. Because 50% time there might be a chance that the patient might deteriorate further unnecessarily.
Thank you. So the message is that if there is a high bilirubin parenchymal disease obstruction, definitely we should release the obstruction by putting a stent, which will bring down the bilirubin and we can try. But if it is a patent duct and it's a parenchymal, and as I said, the 5 is the number. Somebody says 3-fold of the upper limit and somebody says 5. Whatever it is bilirubin, not the SGPT. When it is SGPT, 5-fold of the upper limit of the limit, they say. So if it is bilirubin, then we should look at the performance status. Again, Dr. Vineet Talwar was mentioning that these are the points that we think he is a cancer patient, he's afraid, but it is not always true. A frail patient is not always a candidate for a challenge with chemotherapy, because end of the day, it is a palliative treatment. So we should not put enough burden which he or she cannot take. So if it is a good performance status, still we should go with a single drug. That is a very important point. We should not give doublet, because this type of patient, if there is a response, and then maybe we can think of many other things. So if the CA19-9 is not raised, liver function is normal, and we are giving chemotherapy, how to assess the response? CA19-9 is a parameter, but say we are in a tricky situation. The liver function is static, CA19-9 is normal, but giving chemo. So after 3 or 4 cycles, shall we continue? How can we assess?
If you speak of CA19-9 only, unfortunately, CA19-9 or CA, they are not sensitive markers. They can rise in other cancers also. Although CA19-9 as compared to CA is more specific marker. But then having said that, if you have to rely on any marker, you have to have high sensitivity and high specificity, both, so that you can bank on that marker. Say, for example, in choriocarcinoma, if you have beta HCG high, then definitely you know that this patient is having a problem. So CA19-9 has to be used as an adjunct. It cannot be used in isolation. You have a patient who has all the disease features with a positive biopsy, and you have a raised CA19-9, which is commensurate with the volume of disease. You have a extensively metastatic disease and you have a CA19-9 of say 90 or 100. Doesn't make sense, So CA19-9 in a metastatic disease, in a proven disease, commensurate with the tumor volume and tumor load, then that is the time when you give credence to this marker, but never in isolation.
So thank you, Dr. Vineet. I raised this arbitrary question because not for this disease. Many of our colleagues, we are very crazy about the tumor marker. So yes, it is a good tool, but not the only tool. Rather, we should trust our imaging, clinical things, and all the together, we should take a decision. Looking at a marker, we should not be very happy or very scared. As you said, if it is a part of the game, then it is fine. So last but not the least, MSI was discussed by Sharif that Pembro is showing some promise. So are you using MSI upfront for all or only in metastatic? To use IO, you are using MSI?
Yeah, we are at the onset, we are doing HER, we are doing ROS1, we are doing MSI, we are also sometimes sending KRAS for these cancers because we know that they are not exquisitely chemosensitive tumors, unlike lung or breast or lymphomas. So, in a loco-regionally inoperable cancer or a metastatic cancer, the overall survival ranges between, 1 year, give or take 2 months, up and about. So, if you have any other target which can be utilized, that should be effectively utilized. So, in a cost constraint situation like our country and your country, I think MSI can be done, but then how many people will be able to afford pembrolizumab? That is a different story altogether. Because finances, I strongly believe, is the biggest prognostic factor, leaving apart the academics. In our setting, you have a peon, person who's
Yeah, yeah.
with the officer. So you have a peon who's working in a government setup, and you have a peon who's working in a private setup. The government setup guy gets full reimbursement from the government. The private setup guy, poor chap, has 8,000 or 10,000 or 12,000. So peon in a government service, he will get pembrolizumab, he'll get it reimbursed, but the private setup guy will not get it done. So, the if the patient has a MSI high and is given pembrolizumab, he'll get more quality of life. So that's the way the dynamics work in both of our countries. We are all aware of it. So MSI you can do. MSI will be positive in 1%. And if you have a MSI, you can give it upfront with pembrolizumab. You need not combine it with chemotherapy. Or probably you can give chemotherapy first and leave immunotherapy for later date if the patient progresses. Either ways, combinations you can do. But the benchmark would be the finances.
Thank you. So, that was my last thing, that I totally agree with you that this type of IO and all the targeted drugs, these are very, very rare to happen. And again, the finance is the big issue. Every time it comes to the discussion in our region, because we cannot ignore finance whenever the discussion comes. So I have almost finished my question. Next week, we'll be talking about the hepatocellular carcinoma, and our presenter will be Dr. Arman Raza Chaudhary. And with this question, I think I tried to cover almost all the question in the chat box. There was a specific question of Tract and BRCA. So any comment? Olaparib, I think they are going to put it in every cancer. BRCA is coming here also. But you comment about BRCA in biliary.
Biliary tract cancer, unfortunately, it is not even 1%. It is less than 1% positive. Pancreas, 5%. Ovary, you can go up to 45%. Breast, again, 45%. So, yes, you can check for it. And if it is positive, then nothing like it. You can target it. But again, it is 1% or 2% in GB.
So the message is that when we are having exhausted everything, we should look for anything that we get, like a NGS, whatever it is, BRAF, HAR, NTRAC, ROS1, whatever we get, to find a target to chase. But before that, we need to still, after even 2021, ABC02 is our gold standard, and ABC06 second line is the FOLFOX is our gold standard. I think, after so many discussion, what I realized that where we started with GemCis and the second line FOLFOX, nothing much is there still in our hand, because we, the oncologists, when see a biliary tract cancer, we feel helpless because it comes advanced, and even the ultimate outcome is not a great thing. And surgeons plays the big role, but even sometimes they wish they cannot play the big role because it is beyond their limit. Because if it has gone to the peritoneum or somewhere else, the best surgeon cannot do. Only he can do is he will not operate. That is the decision he or she can take. So that is the situation. So I would like to request, there are some quite a good number of senior faculties also there. We have few minutes time. I mean, almost we have finished the time. But if any of us want to raise any question, you are welcome. I see Dr. Kudrat, I see Alia, I see Arman, many others. Anybody want to raise any question? We can quickly finish and then we can wrap up. Any question? Yes.
Okay, Dr. Kamal, I have a question that is sometimes we are going for PTBD in obstructive jaundice. So when after going for PTBD, the bilirubin is less, maybe less than 5. So should we go for any palliative chemotherapy with these patients, or we will just palliate him with best supportive care?
Yes, Dr. Vinit.
Yeah, if the general condition and performance status is good, ECOG PS0 at 1 and sometimes 2, definitely you should discuss with the patient and give him the benefit of the doubt. If the performance status is still low, PS2 or more, and you find that the patient has a lot of comorbid conditions, then at that point of time, you leave the patient for best supportive care.
Okay, thank you very much.
Because the reason is that most of the times in these patients, the morbid condition of the patient is because of the hyperbilirubinemia. So you should not take a decision when the procedure has been done. You should give a breather of about 1 week. After that, you will find that if it is because of simple surgical obstructive jaundice, the patient will bounce back physically. If the patient is still moribund after that, then that is the time when these patients should be put on best supportive care. Otherwise, you should definitely take a chance, because at the bottom, the accent is to preserve the quality of life, whether you treat them or you leave them alone. For that, you give them about a week or 10 days. The bilirubin has come down. If the general condition improves, go ahead.
Yeah, I think whenever there is a obstructive jaundice rather than the parenchymal, I think there is a better chance, because parenchymal, as you said, is less chance to come up by responding. But whenever there is obstruction, we relieve the obstruction, bilirubin comes down, then we have a fair environment, the PS is good, we can give the treatment, and hopefully there is a better expectation than a parenchymal, if I'm not wrong.
Correct. Absolutely right.
So I think I don't see there is any other question from anybody. Anybody, student, Debraj, any question from you?
No, sir. Thank you, sir. It was a very well-informed presentation.
Thank you.
Covered everything.
Thank you. So I think we are almost 4:40. Normally our time is supposed to be 4:30, but as we started 5 minutes late, so I took the privilege of that 5 minutes. And now I would like to request our president, Professor Ahmed Haisar, to formally conclude the session. But before that, I want to invite everybody for next week. Next week will be our last session on this series, and that will be hepatocellular carcinoma. Believe me, biliary have nothing to do but hepatocellular. Today we have so many things, and I'm sure Dr. Vinit will be much more busy on next week to tell about many things, because there are now so much hope with hepatocellular carcinoma with the advent of IO and combination with targeted therapies, and things has changed so dramatically in last 1-2 years. And we will be listening to Arman on the primary presentation and expert as Dr. Vinit Talwar. Till then, everybody stay safe, and I would like to request Professor Ahmed Haisar to conclude the session formally. Sir.
Thank you, Kamal. We had a very nice session. Thanks to Dr. Sharif Ahmed. He has presented everything very nicely and very thoroughly. He did a very nice job. He had to exercise a lot. And thanks to Dr. Vinit as well. He has described the things, and he is.
Thank you so much, sir. Thank you so much. Appreciate it, sir. Thank you.
Thank everybody else, Kamal, and others who have taken part. So let us say goodbye to everybody.
So thank you, sir. So with that, we thank to our academic partner Acuvida for supporting us, and hope to see you all virtually, meet you all on next Sunday, same time, to listen to Arman about hepatocellular carcinoma, and also to listen from Vinit Talwar that how a hopeless disease is becoming slowly hopeful, even not by only transplant, but also by many systemic therapies. So till then, see you, stay safe, and see you next week. Thank you, goodbye.
Thank you. Bye.
Bye.
Thank you.